Thank you for attending this symposium on the health of women of color, a critical intersection at the corner of sex, gender, and race ethnicity. And today you'll see presentations by 6 fantastic researchers. And right now, I would like to take the opportunity to introduce you to the co-chairs of this symposium, Janine Clayton and Marie Bernard, to give you some opening remarks.
Thank you, Dr. Plank. You didn't introduce yourself. This is Dr. Jennifer Plank, and we're delighted to have you all here. And I'm particularly excited that we are able to talk about this really important subject at the NIH Research Festival. So you can see our little graphic here that we're very concerned about the health of women of color, and one of the ways we're thinking about this as a critical intersection at the corner of sex, gender, and race ethnicity. And we do think this is so important that we actually spend extra effort to try to get data disaggregated by sex, gender, and race ethnicity simultaneously so that we can look at what is occurring in various populations of women of color. And the Office of Research on Women's Health will be releasing the Women of Color Health Data Book. This is the 4th edition. You should have a little card in your materials there. It'll be released as an ebook. And of course, one of the statistics I want to share with you in terms of setting the stage is the fact that by 2043, the United States will become a majority minority nation. And I don't know if that means we should just stop using those terms, since that's where we're going, and really prefer to use descriptive terms to talk about different populations of women, because I don't think that it's helpful to define one group of individuals in the context of another group. By 2050, women of color will be 53% of the total U.S. female population. And so the Women of Color Health Data Book is going to have information that I think will be helpful to scientists and clinicians alike. We know that the leading cause of death in women is heart disease. In general, however, if you look at populations of women of color, you can see there that it actually varies, and that cancer is the leading cause of death over heart disease in Asian Pacific Islander women, Hispanic women, and American Indian, Alaska Native women. So that gives you an idea of when you start to look at populations of women of color and really carefully parse that out, what you start finding differences. And so we'll be talking about this critical intersection, and I wanted to just share with you in the context of this session where NIH and the Office of Research on Women's Health is looking at this issue beyond inclusion, beyond looking at including women and minorities in clinical research. We're thinking about it as sex and gender influences. So we're thinking about this as an important issue that needs to be infused and integrated throughout the entire research continuum, from the basic to the clinical to the translational, and that sex and gender, considerations of sex and gender, need to be incorporated at the preclinical level. So when you're doing those animal studies, looking at male and female animals, when you're doing cell culture, understanding whether you're working with male or female cells, because that can make a difference in your preclinical work. Clearly in toxicology, we know that this is important, and different compounds and chemicals interact and affect men and women differently, and that's already considered throughout every phase of the clinical trials continuum. In terms of reporting sex-specific data, so that that data gets out in the literature and you can parse the data different ways, sex-specific analyses and reporting, and then education and health policy, and ultimately informing healthcare, because clearly why we are doing this here at NIH is to inform and improve health. And if I recently added my phase 4 block there. So at this point, I want to turn the podium over to my esteemed colleague, Dr. Marie Bernard, the Deputy Director of the Aging Institute.
So I'd like to join Janine in welcoming you all, and thank you for being here. It's nice to see the room packed and the need to bring in more chairs. This is a symposium that was proposed by the Women of Color Committee of the NIH Working Group on Women in Biomedical Careers. And you see listed here the members of that committee. Dr. Belinda Cito, the deputy of NEI, co-chairs this committee with me. And I particularly would like to acknowledge everyone on this committee has been really busy helping to make things move forward, but I particularly like to acknowledge Debbie Cohen from ORWH for support for things, Cerise Elliott from NIA, who has been the backbone to the Women of Color Research Network. Let me go down my list to make sure I'm getting everybody. Wendy Lee and Kate Nagy, who've been doing the Spectrum blog, Roland Owens, who always has a lot of sage advice for us, Jennifer Plank, who really has made this symposium go forward. Golda Phillip and Sarah Williams, who've developed some regional networks for us. So let me tell you what I mean when I talk about those things that I've acknowledged. The Women of Color Committee was established to address the unique needs of women of color in the sciences, including recruitment, retention, and career advancement. The work that was reported in Science in the summer of 2011, led by Donna Ginter, analyzing racial and ethnic representation in NIH grants, has led to us to have some subsequent discussions with Donna, where she did further analyses of that intersection between race, ethnicity, and gender, and has led us to be reinvigorated in our attempts to facilitate things for women of color in science. So we have the Women of Color Research Network, a social media site that was established by Dr. J. Taylor Harden and Cerise Elliott. I guess that was 2007 or 2008, is that right? 2009, so it's very young. From that has grown the Spectrum blog, which is posted once a week with lots of good information. If you are a woman of color in the sciences, if you're interested in issues for women of color, it's a great resource for you to take a look at, the WOCRN site as well as the blog. We've been trying to systematically nominate women of color for lectureships and awards, and this symposium is part of that process of our recommending women to increase their visibility. And from the Spectrum blog and the Women of Color Research Network, we've now been able to get some local chapters of women in color committees established in Indiana and North Carolina. And the WOCRN at .nih.gov, if you're not familiar with it already, I would encourage you to take a look at it. Again, you don't have to be a woman of color to benefit from this. There's lots of information about ongoing events, how to go about getting grants, what to do when you are thinking about what to do after your postdoc. There's more than 1,400 members of it currently. It's an opportunity to network and get mentoring, and so I would encourage you to take a look at it. And before I turn the podium back over to Jennifer, I would just like to point out that you have handout materials from ORWH as well as NIA, and my NIA colleagues would kill me if I didn't point out that in the back you have what is your aging IQ, a workout to go, what's on your plate in terms of nutrition and aging, and things about menopause. So take a look at the materials in the back as well as the things on your desk. Jennifer, it's all yours.
Thank you, Dr. Clayton and Dr. Bernard. And so with that, I would like to introduce our first presenter, who is Dr. Lauren Wood. She is a staff clinician at the vaccine branch at the Center for Cancer Research, and today she will be presenting on the advances and challenges in the clinical translation of therapeutic cancer vaccines.
Well, I want to thank the organizers for the opportunity to present at this symposium. My research is not specifically going to be addressing issues of gender and ethnicity in terms of the conduct of clinical trials, but I hope as an individual who focuses on first-in-human trials and clinical translation of novel immune-based therapies and therapeutic vaccines for cancer, which clearly, as Dr. Clayton highlighted, is a major issue for women of all ethnicities, that I can highlight some of the issues that we face as we translate clinical vaccines. Within the vaccine branch, the focus of our research is novel vaccine platforms that are developed by laboratory PIs within our branch into first-in-human studies. And actually, I'm going to be talking about a peptide vaccine that was developed for men with prostate cancer, but actually has relevance in future clinical development, we hope, for women with breast cancer as potentially a novel therapeutic target. So some of the inherent challenges that we face when we are dealing with the immune system has got to do with the complexity and the redundancy of the immune system, the fact that tumor antigens are self-antigens that the patient may actually have become tolerant to, that immune dysfunction and evasion by these cancers allow them to avoid eradication, especially in patients who have advanced metastatic solid tumors, which are the majority of patients. Most patients present because of symptoms, and at the time of their diagnosis, they have advanced disease, and this is particularly true of racial and ethnic minorities who present, especially especially with colon, prostate, and other types of cancer, as well as breast cancer. The anti-tumor effect of cancer vaccines is really indirect. Unlike chemotherapy, where we can basically drop the bomb, know that it will hit the target, also probably cause some innocent bystander damage to normal healthy tissues, vaccine therapies are indirect by nature. We have to first stimulate the immune system to make an appropriate anti-tumor immune response, and that immune response then has to ultimately end up eradicating tumors. What I'm going to focus on, because of the nature of the peptide vaccine that I'm going to be discussing, I'm going to focus on two issues. Tumor antigens that are self-antigens, as well as the issue and challenges of the anti-tumor effects and the fact that they're indirect. So the key function of the immune system basically is to distinguish self from non-self, but more importantly, it's also to distinguish danger from things that are not dangerous. So it's a combination of the self, non-self, and the danger, non-danger that basically correlates how an immune response is directed. Now, usually self is not dangerous, and typically and classically anything that is non-self is considered dangerous. The main problems that we see characteristically in immunity is that either we have too little immunity, so we have immune compromise that's associated with malnutrition, cancer, HIV infection, other immune deficiency diseases, very, very common in this age of transplantation of organs. We can have too much immunity, where the immune system is basically overactivated. We know clearly from pathophysiology and preclinical animal models that chronic inflammation is associated with the development of malignancies, independent of whether or not there's also associated chronic persistent viral infection. Self is seen as dangerous. This is a problem when we have problems of autoimmunity, which disproportionately affects African American women who are affected by lupus. Other examples of autoimmunity include inflammatory bowel disease, rheumatoid arthritis. Again, this element of dysregulation is not a good thing. And it's also a problem when non-self is not seen as dangerous as what we see when we have established infections that are chronic and persistent, such as with human papillomavirus, hepatitis B, Epstein-Barr virus, hepatitis C, which ultimately can lead to inflammation. So here's my quadrant of the good and the bad, of self versus non-self, danger versus non-danger. And up across the x-axis, we have self versus non-self, and along the y-axis, we've got danger and non-danger. When there is a danger signal, and self is seen as dangerous, it's bad. That's what you get, autoimmune disease. We don't want that. When non-self is seen as dangerous, that's good. We want to reject things that are non-self. When it comes to self, we want it to be seen as non-dangerous because basically that's good. Self is not attacking self. There's health, there's immune system is in balance with self tissues, and they're healthy and balanced, and there's no autoimmune disease. If non-self, which is foreign, is not seen as dangerous, then the non-self becomes tolerated. And that's what we see with chronic persistent infections such as EBV, hepatitis B, that leads to chronic activation, chronic inflammation, and ultimately to malignant transformation. So how I am charged as an immunologist with trying to harness the immune system to attack self-tumor antigens is that I have to deal with the fact that the immune system accomplishes its functions because it always presents everything in the context of self. Self is described by the human leukocyte antigen system. It's the major tissue histocompatibility that's done when everybody gets transplants, and they constitute our tissue type, and it's the main reason why donated organs or tissues are either accepted or rejected because they need to be matched. So this is my handprint analogy of what the immune system sees. Just like everyone here has a unique fingerprint, so your HLA tissue type is your unique fingerprint. This is what the immune system sees. And when it is rejecting things that are non-self or foreign, it is actually seeing these in the context of yourself. So the orange triangle, the green octagon, the blue triangle, the yellow sun, those represent non-self foreign agents that are presented in the context of self. Well, they're easy to get rid of and easy to reject because they're non-self. The challenge that I have as an immunologist in cancer is that we have are self-HLA tissue type, but then what we've got that's being presented to the immune system is we've got awkward self gone bad. This is clearly a jacked up hand, but it really doesn't look that much different from the other one, okay? And what I've got to do is take this jacked up self that's gone bad, and I've got to somehow enhance the danger signal and train the immune system to recognize it as dangerous and to be rejected. So again, cancer is self gone bad, but it's still self. And that's probably the number one challenge in immunology in terms of translating this. So now I've modified our quadrant box so that bad self, which is cancer, is not rejected. That's the problem. It's part of self, but it's not seen as dangerous, so it's not rejected and it gets established. So the take-home message from that is that for our therapeutic vaccines, we have to develop effective vaccines, not only for cancer, but for chronic persistent infections that have better antigens, that have better danger signals, and that overcome mechanisms of immune suppression and immune resistance. An example for that is blocking negative regulation. That's a very hot area in cancer immunotherapy. A new negative checkpoint regulator was approved just 10 days ago by Merck. I want to finish up by highlighting the fact that the anti-tumor effect of cancer vaccines is indirect and give you an example of that in a first-in-human clinical translational trial that we have. One of the issues that we know is that clinical responses to immune-based therapies take time. So unlike oncologists who are able to deliver chemotherapy and drop the bomb per se, as we deliver therapeutic cancer vaccines, I've actually got to train the special ops forces to shoot right, to arm them with bullets, to make sure that they hit the targets, and then to make sure the targets are ultimately killed. And that does take a little bit of time and training. Oftentimes we see with immune-based therapies there can actually be very, very important and highly statistically significant improvements in the clinical endpoint of overall survival, but oftentimes we do not see any differences in progression-free survival. And part of that has got to do with the fact that actually patients who get immune-based therapies sometimes demonstrate progression before they demonstrate regression. And this is because of the fact that if you do harness an anti-tumor immune response and you start to see destruction and necrosis of local tumor tissue, you get local inflammation at sites of tumor, but they all look worse on CT imaging scans, and oftentimes micrometastatic disease that was previously invisible, once there is a focal anti-tumor inflammatory response, actually becomes visible, and it looks like there are new lesions or more lesions there. Generally, our immune-based therapies are really more effective in patients who have minimal burdens of disease because there's tremendous dysregulation when patients have advanced solid tumors, and reliable validated surrogate markers for clinical responses are often lacking, and that's actually what I'm going to demonstrate for you. TARP is a 58 amino acid protein. It was actually discovered by Ira Paston and colleagues here in the NCI. It is expressed in about 90 to 95% of prostate cancers, which is why we started in men first, but it's also overexpressed in about 50% of breast cancers. It uses a different open reading frame from the normal TCR receptor gamma. In their initial description, Dr. Paston and colleagues identified the fact that even though TARP was expressed on normal prostate epithelium, it was actually due to the epithelial cells. It's expressed at the mitochondrial level, but it's not due to infiltrating tumor cells. So it's actually unique to the prostate organ. It's also expressed in breast cancer, and importantly, work by others has shown that it's highly expressed in primary as well as metastatic prostate cancer in patients who have a range of aggressiveness in terms of histopathology. Gleason score is associated with disease aggressiveness in prostate cancer, and it's important that it's also expressed in hormone-sensitive as well as castrate-resistant prostate cancer, making it an ideal candidate for clinical translation. So I'm going to present 5 quick slides regarding a first-in-human trial that we did of a peptide vaccine. I can't go into all the preclinical animal models and testing that were done that led to the human clinical translation, but we did this study in men who have D0 prostate cancer, which means they've been treated for their prostate cancer, but they have evidence of PSA biochemical recurrence. Their PSA levels have come up after radical prostatectomy or radiation therapy, but they have no evidence of bony or visceral metastatic disease. We used 2 TARP peptides. The scientific principle incorporated in our platform was that one of these peptides was the wild type form and another was an epitope enhanced peptide. Basically, we made a single amino acid substitution to the peptide and could document that we could enhance the immunogenicity and the immune responses and the cytolytic responses to the peptide that was epitope enhanced. We delivered the peptide vaccine either with montanide, which is an adjuvant in GM-CSF, or we custom made an autologous dendritic cell vaccine and delivered it to these gentlemen, the ultimate in personalized cancer therapy. Our primary outcomes were safety, toxicity, and immunogenicity, but we also wanted to see if we could slow the rate at which the PSA was going up in these men, because it is a correlate with clinical outcome, overall disease progression, and survival. The one thing that I want to show you is that as the PSA goes up, we can calculate the slope. PSA doubling time is the really very clinically relevant outcome that most clinicians are interested in. The bottom line is you don't want a PSA doubling time less than 3 months because you're at 100% risk for progressing and dying from your prostate cancer. And if your doubling time is greater than 15 months, the issue is that it could be 5, 10, even 15 years before your prostate cancer is a problem for you. So our goal with our TARP vaccination was basically to slow the rate of rise of how fast the PSA was going up. And ultimately, we look at the slope rather than the doubling time because actually, when you totally slow the rate at which the PSA is going, the doubling time actually goes to infinity. And when you actually lower the PSA doubling time becomes negative. So the takeaway from our first trial was that in this group of men, we had a highly statistically significant slowing in PSA doubling time. The thing that I want you to take away is that the majority of men are on the right-hand side. This represents a change in their slope from pre-vaccination to post-vaccination, and it shows that we're slowing the rate at which the PSA is going up. It's highly statistically significant, and it's seen actually in the majority of patients. This is at 24 weeks. And we saw the same thing at 48 weeks. Good, I'll get the last 2 slides in 2 minutes. The other thing that we saw was that we met our primary immunogenicity endpoint, that the vaccine was indeed immunogenic, and it increased TARP-specific reactivity. Here we have, at week 0, no evidence of TARP-specific reactivity, and again, no evidence of TARP-specific reactivity. And at weeks 12, 18, 24, it did not matter whether we tested it to the TARP wild-type peptide, which is in light blue, the epitope enhanced peptide, which is in the medium blue, or the native conformation of the non-vaccine wild-type 2937 peptide. We saw an increase in immunogenicity. Highly statistically significant, it was in the majority of men, and wonderfully, which kind of rarely happens in clinical trials, it completely recapitulated what we saw in the preclinical animal models. But the bottom line is that the people who were responders and had a slowing in their PSA velocity had the same kind of TARP reactivity as non-responders. So the bottom line is that even though we have a very clinically relevant surrogate outcome, we have immunogenicity, we have the issue of, I did something to the immune system. The immune system had a clinically relevant effect on a surrogate of outcome. It was immunogenic. But my immune response doesn't correlate with my clinical outcome of interest. And that is one of the major challenges of therapeutic vaccines. So I wanted to highlight that as an issue of the challenges that we deal with in clinical translation. And thank you very much for your time and attention.
Thank you very much. Does anybody have any quick questions for Dr. Wood?
I'm going to go get vaccine, but I'll answer the questions real quick and then I'm going to come back. What were the questions?
Oh, I'm not going to that was a really good talk. Over time, do you see any T-cell memory responses that are specific?
We absolutely do.
Immune suppression over time.
So we do see TARP-specific T-cell responses. I didn't have time to go into the details of this particular assessment of immunogenicity, but it was by interferon gamma ELISpot. So all of these are T-cell responses that were documented that are TARP-specific. We tried to look at, because there was no correlation with interferon gamma ELISpot reactivity, we looked to see if there was correlation with TARP-specific reactivity as measured by granzyme or perforin A or granzyme A, granzyme B, and we still have not found anything. We are continuing on our fishing expedition because the immune system is infinite, and we're looking at activated TARP-specific CD8 cells to see maybe that might be a surrogate of whether or not individuals had that slowing in PSA velocity. That it's not only TARP-specific cells, but are they activated TARP-specific cells? We're also looking to see whether or not we see TARP-specific CD8 cells that have evidence of polyfunctional cytokine expression, because that's been shown to correlate with actual functional anti-tumor activity.
I was wondering about the new negative checkpoint regulator.
Yes. So the first one to be approved was for malignant melanoma 2 years ago. It's anti-CTLA-4, also known as ipilimumab or Yervoy. And the most recent one is a Merck anti-PD-1 inhibitor, okay? I am really excited as an immunologist because literally 4 years ago when Provenge was approved, the oncology community was like, that's voodoo, it doesn't work. The immune system, not important, we don't care about it. But now, with the activity and the success and the clinical responses that individuals are seeing to the checkpoint inhibitors, where basically tumors are able to express and secrete immune system proteins that put the brakes on the immune system. So the immune system is trying to attack the tumor that's gone bad, but the tumors are able to overexpress these negative regulators that then put the brakes on the immune system. So the hunt is out in multiple areas of biopharma to develop monoclonal antibodies to these checkpoint inhibitors that in essence take the brakes off the immune system and allow multiple parameters and arms of the immune system to have at the tumors and actually result in regression of tumors and clinically very, very relevant outcomes.
Okay, we'll wrap up here and we can continue questions later in the discussion.
Good afternoon. My name is Wendy Lee, and I'm a biologist at the National Institute of Allergy and Infectious Diseases. And I'm also a proud member of the Committee on Women of Color in Biomedical Careers that Dr. Bernard previously spoke about. It is my pleasure to introduce to you Dr. Nakela L. Cook, who is the Chief of Staff in the immediate office of the Director in the National Heart, Lung, and Blood Institute. And she'll be speaking to us today about cardiovascular risk and treatment at the intersection of race, ethnicity, and sex. Dr. Cook?
Well, it's a pleasure to be here this afternoon and be able to speak to you about something that's very important to us at the Institute as well as to me personally. I'm particularly looking at the risk and treatment of women with cardiovascular disease as the risk and treatment of women with cardiovascular disease, but specifically, I wanted to take an example of heart failure and some of the conversation and talk to you about some of the risk there that's particularly of interest around women of color. So many would say, why is this even important? And I think it's actually important to think about this in a way that bridges a gap, because we know that women represent half of the patients with cardiovascular disease and half of the patients with heart failure in this country. And as we saw from an overview that Dr. Clayton gave us, is that overall it's the leading cause of death for women. Although when you start to break it down by race and ethnicity, we know that there are certain ethnicities where this is a second leading cause of death behind cancer. And there are known differences that are both reported in the epidemiology as well as the care and treatment and clinical presentation for women with heart disease. And the clinical outcomes among women have improved over time, but not as dramatically as it has for men. And thus, we know that there's an attention that needs to be given to the health care disparities that we see for women as compared to men. And we know that healthcare disparities exist in evidence-based treatments that are not being given as regularly for women, and specifically when you look at that intersection of race, ethnicity, and gender, that we actually see lower rates of evidence-based care. And specifically, symptoms are under-recognized, and women have been historically underrepresented in the trials that actually provide that evidence base for the therapeutics that we use on a regular basis. And not just that it's a socially important and socially just thing to do, but it's also politically important in that we know that there are many members of our congressional body that are also interested in us improving the care of women with heart disease. So maybe women are from Venus and men are from Mars. We know that there are differences in biology and pathobiology between the sexes. And just as an example of how this is manifest is cardiovascular disease affects women at an older age than it does men. And why is that the case? And is there some hormonal interactions that actually protect women at an earlier age? And we do know that amongst a certain condition in heart disease, it's called Takotsubo's cardiomyopathy or stress-related cardiomyopathy, that 90% of those affected are women. So why is that the case, and what's the biology and the pathophysiology behind that? At NHLBI, we sponsored a study called the Women's Ischemia Syndrome Evaluation, which basically evaluated what exactly happens in a woman that has a cardiac event but doesn't have an obstructive lesion in a coronary artery that can account for that event. And the whole syndrome of microvascular disease, the entity itself, was defined in this study, which seems to be something that predominantly affects women. So again, a different pathophysiology that seems to be present at time between the sexes. And we know there are documented differences, as I mentioned, in the burden of cardiovascular disease amongst the sexes. And if we look at a remaining lifetime risk of cardiovascular disease at age 40, we see that 1 in 2 women are likely to develop cardiovascular disease after the age 40 in terms of their lifetime risk. And when you look at men, it's 2 in 3. And specifically, if we narrow in on cardiovascular disease deaths from coronary disease, stroke, or heart failure, you actually see these differences start to occur where there's a slight bit of balance between what we see in terms of deaths and overall cardiovascular and congenital disease. But when you delve a little deeper for coronary disease, you see that the deaths for women are less than that of men, and hospital discharges less than that of men. But when you start to look at stroke, you see higher rates of stroke and deaths amongst women as compared to men. And heart failure itself, while there's a lower prevalence of heart failure among women in this overall population survey, when you look at actual hospital discharges, there are a larger number of hospital discharges amongst women as compared to men. So some imbalances there and documented differences that we know in the burden of disease. But there are also documented differences in treatment. And this is actually, I think, an area where we have lots of opportunity for improvement. And when we have looked over the years, we've proven through many studies that women are less likely to get early medical interventions when they present with heart problems. They're less likely to get invasive cardiovascular procedures for treatment and therapy. They have shorter, or I should say longer times for reperfusion, which is actually opening that blocked artery when they come in with a heart attack. And in hospital, their death rates are higher than men. And so we definitely know that disparities in the treatment can contribute to poorer outcomes, and this is an area where we can actually make a difference in care. And if I drill down more specifically, and I'm using the case example of an implantable cardioverter defibrillator, or one of those therapeutic treatments that usually we use in patients that have a reduced ejection fraction with heart failure, where we're actually trying to allow the heart the opportunity to be shocked back into a normal rhythm if a life-threatening rhythm persists. And when we look at the data from the American Heart Association Get With the Guidelines registry, we actually find that there are differences in the rates of receipt of this life-saving intervention amongst women and men. But what I think is particularly striking is that when you look at that intersection of race and ethnicity as well as sex, you see that Black women are the least likely to have an implantable cardioverter defibrillator in this data set. Now that data is back from 2008, so I was interested in looking at some trends over time in order to understand if we've seen any differences since some of these early reports. And the graph that's there on the on the right for you, or I guess on your left, basically shows that overall we've seen some improvement with, in terms of the race ethnicity receipt of implantable cardioverter defibrillators, but still those in the dotted lines, the female patients, still lack under the male patients in terms of receiving this device therapy. And this data has shown us some trends over the last 4 or 5 years. So we know that early reports with differences by race and sex do exist in ICD use, and Medicare recipients between years 1999 and 2005 show that overall women were 75% lower, had lower rates of implantation as compared to men, and that recent reports do show this narrowing in the race ethnicity gap, but do not show that narrowing for sex differences. Drilling a little bit deeper in heart failure, because I think it's an interesting case study. If we look over time with mortality in heart failure, we see that there's been improvements in general. You see the trend actually declining in terms of deaths per 100,000 of the population. But again, if you start to look at the rates of Black women as compared to men, Black women on average are falling right along that line of white men, which is a much higher risk and much higher rate of death as compared to that of white women. And this graph I actually think shows it a little bit better, because you can directly compare those two green bars, and you see that essentially when you start to look at where Black women fall in terms of heart failure mortality, they're more equivalent to that purple bar over amongst men. So much more equivalent to the rate of death as white men as compared to their white female counterparts. If you delve a little bit differently in terms of incident heart failure, so we were looking at mortality and death rates before. If we look at incident, we actually sponsored a very interesting study at the Heart, Lung, and Blood Institute a while back, when we had this cohort called the Cardia cohort that many of you may be familiar with, that actually looks at young adults and followed young adults from the ages of 18 to 30 over the next 20, 30 years, and actually found that incident heart failure that occurred at an age less than 50 years of age was substantially more common amongst Blacks as compared to whites. And if you look at the orange line, that's the Black women, and you actually see that that line crosses over the Black men and continues to rise in this graph. And we're interested in seeing where the follow-up is going to be years later in this cohort, but we're concerned about this trend where 26 out of the 27 cases of incident heart failure occurred in Blacks, and the majority of them in Black women. And when you start to look at other cohorts that we sponsor, such as the ERIC cohort, we also looked at heart failure incidents there amongst our, it was a middle-aged cohort, so a little bit older cohort than the Cardia patients or participants. And what we found there is that Blacks had the overall highest incidence of heart failure in that cohort as well. With Black women, if you categorize them as less than 60 or over the age of 60, Black women over the age of 60 with the highest rates of any other group. And this graph that's overlaid here just shows you now after incidence, if we start to look at survival as after incident heart failure in that same cohort, that survival after incident heart failure hospitalization was significantly less for Black men and women as compared to the white men and women in the cohort. We have seen some narrowing of gaps. We talked about the implantable cardioverter defibrillator narrowing and the race ethnicity gap, but the sex gap persisting. And if we look at hospital discharges for heart failure, we're starting to see some narrowing in the sex gap. So over time, we are seeing some level of improvement. And we also are seeing that overall cardiovascular disease mortality for women in that red line is now approaching that closer to where men have been, and the decline is starting to catch up, but there's still lots of room for improvement. Specifically, there are lots of challenges in trying to address these gaps, and I want to take a couple of examples from the literature to show you some of these challenges. But one is that we have to gather the necessary information amongst women in order to really understand if there are therapeutic treatments that need to differ for men as compared to women. And I highlight this one. The glycoprotein 2B3A story is an interesting one. This is actually basically a blood thinner that's used in the setting of a heart attack, and particularly when someone's having an intervention that's going to open the artery that's blocked. And early on in the usage of glycoprotein 2B3A inhibitors, there was some concern that the early trial data didn't show as much of an effect for women as for men. And some actually thought that this was because there weren't enough women included in the studies to actually prove that benefit. But the challenge clinically was that people were raising the question and not using the evidence-based care for women because of this concern that it wasn't as effective for them. So several meta-analyses later and years later, there was a proven efficacy of GB2B3A inhibitors for women. And one of the then raised issues became, well, women tend to bleed more than men, so are we sure it's safe? And additional studies had to be done in order to understand that, yes, indeed, there was an increased rate of bleeding amongst women as compared to men. But actually, that increased rate of bleeding, almost 46% of that was accounted for by overdosing. And so understanding the appropriate dose and targeted dose strategies actually made this a very effective strategy for women and educated the clinical community. So gathering the necessary information was key in this situation. We also saw in a very similar fashion as we start to progress with more sophisticated cardiovascular devices that questions were raised about whether women should even receive left ventricular assist devices. And these are devices that actually support the pumping function of the heart in a failing heart and can often be used to bridge towards a cardiac transplantation or even as final therapy for someone with heart failure. And one of the registries that is sponsored by the NHLBI decided to take this question on and really look at whether or not women should be receiving this device. Again, this is a scenario where only one device was originally tested in the early trials. The device was too large to actually be implanted in many women, so the evidence wasn't there in order to be able to really provide the clinical impetus to use the device. And actually what we found as they really kind of delved into this issue is that in fact there was no difference and that women had the same degree of benefit from implanting this device after smaller devices were developed and were able to be used, as showing that actually gathering that necessary information basically staved off the unintended consequences of the low enrollment and inclusion in the trials. One last example is that there had also been concerns about whether or not women had increased adverse events from a left ventricular assist device, and there was concern that there was more bleeding, there was more infection, there was more neurologic dysfunction and device malfunction in women as compared to men. Again, the investigators took this on and did find actually that there was one important difference. There were no significant sex differences in mortality, bleeding, or infection in this study, but they did find that women had a shorter time to a first neurologic event. And that's something that actually deserves more clinical attention as well as more research attention and has prompted more studies in this area in order to understand what the difference is here in terms of the implantation of this device in women as compared to men. And the last example I'll show you is around sex-specific differences for resynchronization therapy. And so this is also used in heart failure. And there's a class 1 indication, which means the highest recommendation of using this device in patients that have a certain finding on their ECG. And one of the questions that was raised is whether or not actually this would be beneficial for women at lower ranges of this duration of their QRS interval in the ECG, because there were some early hints at this, but there wasn't a real indication from the guidelines perspective to implant these devices in women. So actually what we found is that women had a 76% relative reduction in heart failure or death when they actually used this device at a different interval than where men actually have this. So the range of possibility for when a woman would benefit from this device was much greater than that for a man. And the findings persisted in adjusted analyses as well as in a replication of this study. So again, it's getting the necessary information in women and really doing the sex-related analyses and reporting that's important. I will pass over this last example. It's again about implantable cardioverter defibrillators. Again, a question raised as to whether they're even effective in women, and similar types of analyses that showed as equal effectiveness for men as for women, and that guideline-directed ICD therapy would be associated with reduced mortality for women and should be implanted regardless of gender. So there are lots of barriers to including women in clinical trials and also unintended consequences, as we talked about, of the underrepresentation of women in our cardiovascular studies. There really has to be an active consideration of differences in etiology and pathophysiology when we talk about inclusion. And inclusion-exclusion criteria can sometimes unintentionally exclude women. Women tend to be of older age and have more comorbidities and be frailer. Frailty is an issue when they come to presentation for cardiovascular disease, so enrollment in studies can be more complicated. But there can also be an underdiagnosis and under-referral, which we've talked about. Pregnancy concerns and family responsibilities can be of concern for inclusion. But what we find is that if you have criteria that focus on symptoms, etiology, or pathophysiology that are more common in men or that were developed based upon symptomatology studied in men, that women may unintentionally be excluded, that risk scores that underestimate risk in women could actually unintentionally exclude women. And criteria for medical devices that are based on size can be a problem if there's only one device and the device is too large in order to be implanted in women. And upper age limits can sometimes exclude women who present, for example, with heart failure, as we talked about, in an older age. So there's still a lot more work to be done to achieve sex equity in cardiovascular care and outcomes. And we talked about the need to increase enrollment in clinical trials. We talked about the need to do sex-stratified analysis, sex-specific analyses, and sex-specific research when questions arise where evidence-based therapy may not be given to women based on some of the challenges. And we also highlighted this intersection of race, ethnicity, and sex, where research focused on special populations with greater risk and disproportionate burden and poorer outcomes is extremely important. And lastly, I want to mention that we have to ongoingly monitor our healthcare system differences in order to even know if there are differences in treatment and outcome that persist. So the trend data beyond the initial data is very helpful in understanding where we need to delve more deeply. With that, I want to thank you for the time, and I hope that this was informative.
Thank you, Dr. Cook. Our next speaker is Dr. Gina Brown. She is the coordinator of Women and Girls and Microbicides Research in the NIH Office of AIDS Research. Dr. Brown.
I just want to thank you for inviting me to come and do this. I think it's really important that these issues that are being discussed today are actually something that's brought to the forefront. And in particular, my area of work is around the issues of women and girls and HIV, that often we get lost, meaning women get lost in this HIV discussion, particularly in this country, but in fact it is a considerable issue. And so what I'd like to talk to you about today is an effort to take a look at one particular issue around the risks of HIV in women and give you an example of how NIH is really looking at what's the research that needs to be done. And so what I'm going to talk about is sexual violence and HIV risk. I'm going to spend a little bit of time trying to give you some definitions so you know exactly what it is we're talking about, and then get to kind of what are the research efforts that are being put forth and being led by the National Institutes of Health. So 1 in 3 women, there's the Centers for Disease Control does something called the National Intimate Partner Violence and Sexual Violence Survey about every 2 years, and then they'll report it for the 2 years. So the data that we have is from 2010, got reported in 2012. Coming up over, probably by the end of this year, we'll have the data from 2012 that will be reported in 2014. So this is the most recent that we have. In the year preceding the survey that they've done, and they do this as sort of telephone interview, mailing out questions for people to answer, and then having someone sit down and go through, and it's considered to be this work is considered to be one of the most representative samples that you can possibly have across the United States. So in the year preceding the survey, 1.3 million women admitted to being raped. 1 in 5 women admit that will have been raped in their lifetime as compared to 1 in 71 men. Granted, all of this is probably quite underreported, but that we can probably all agree that there's a considerable imbalance here in terms of who's more likely to be raped. 1 in 5 Black women and 1 in 5 white women. And I think this is important because if you look at the news, it looks as though it's largely a Black or African-American women's issue, and that in fact is not true. And about 1 in 7 Hispanic women admit to being raped. If you ask the question in a given community, you'll get an answer for that given community. So if you ask the question in the African-American community, you'll say, oh my God, there's an awful lot of this going on, but it has to be considered as compared to what? 1 in 4 women will experience some severe enough physical violence in their lifetime by an intimate partner, as compared to 1 in 7 men. And 1 in 2 women in their lifetime will have experienced some form of sexual violence. The rates of intimate partner violence, sexual violence, childhood sexual abuse, and HIV-infected women is twice the national rate. And so that's why we're starting to pay attention to this issue with respect to HIV-infected women. There's an absolute definition of what is intimate partner violence. You can get it off the Centers for Disease Control website, and this is how they make sure that they're asking exactly the same questions of all women. This is pretty much the same definition that the World Health Organization also uses, so that we can look at international data as well and consider it to be quite similar. And what I want to point out is that sexual violence isn't the only intimate partner violence, it's also physical violence, but the other thing that's achieved some level of notoriety in the news and other places has been this issue of control of reproductive or sexual health or control of finances, which also counts as some amount of intimate partner violence. I'm an obstetrician gynecologist, and I would have women who could not come to see me on their given appointment days because their partner wouldn't allow it. And so it's something that affects more than just, the physical health as a result of the violence, but it also affects a woman's physical health as a result of her ability to get care when necessary, and it's particularly care when she's been attacked. Even the emotional threats of physical or sexual violence will have impact. So I always thought, why are we using this term intimate partner violence? I mean, what does this mean, particularly when you're talking about sexual violence? And the thing that really kind of threw me was that when you look at rape, 51% of the time is by an intimate partner. 40.8% of the time it's by an acquaintance, someone this person knows. So almost 92% of the time when a woman is raped, it's by someone that she knows. It's not the stranger as you walk down the dark corridor in the street quite as much as it is the stranger who may appear in your home, in your bedroom, in your social circle, that is the person who's the rapist. So there are absolute definitions of what is rape, and what we're going to talk about specifically around these research issues is what's considered to be a completed rape, where it's penetration. But you can see the long range, which could lead a number of people to not even quite be sure. The sexual coercion, being pressured, feeling like you've got to go along in order to either not have some other method of violence, or just kind of trying to make good, kind of the position that women often find themselves in. And then there's the non-contact sort of things that people may come across sort of every single day in their daily work lives that they may or may not admit that's been part of what's considered to be sexual violence. But in particular on these research issues, I'll focus in on the issues of penetration. So the other thing I want to point out is, again, this is something else that kind of dropped my jaw, and I had a colleague look at my slides, just to make sure that I've got no typos and, the sort of thing, what you want to say, and you think that's what the slide says, and it may not exactly say that. So we were looking, and she said, oh my God, I can't believe this, which is 42% of the women who are raped in the United States, it's happened by the time they're 18 years of age. And 80% by the time they're 25 years of age. And so it's a real issue amongst young women. However, you can't discount that if you look at the pie chart, that if you look at yellow women over the age of 45 years, 2% admit to having been raped, or to being raped rather, and then at the time of their first rape. And 35 to 44%, another large 5%, and then 25 to 34% at 14%. So it's not something that doesn't come across the age range, but it's certainly something that young women have to contend with. So typically the way we've looked at this issue, particularly in the research world, is we think of it in terms of there's sexual violence, and it's either direct transmission. So in the course of being sexually assaulted, a woman is at risk for getting HIV infection. And we've built an entire care system around that in the emergency rooms pretty much across the United States, and I have to say probably started in New York, is that if you've been sexually assaulted, you go to the emergency room, and in addition to getting a pregnancy test and an emergency contraception, you'll also get an HIV test, and if that rapid test is negative, you'll get post-exposure prophylaxis, or a month's worth of antiretrovirals to take to prevent you from getting HIV infection. So we've built an entire system pretty much across the United States to kind of deal with this issue for women who do seek care. The other issue, though, we talk about when we look at research is if you get this history of sexual violence and kind of look at women who ultimately have HIV infection, it's these issues of being so put in such a position of lack of power that your negotiating skills around sex are compromised, even with your given consensual partner. Being able to negotiate condom use is much more difficult in someone who's had sexual violence than in someone who's not. And that's one of the things that stands out in terms of looking at particular studies, there's a long-term follow-up study called the Women's Interagency HIV study that's done in the US. And one of the things they've been able to point out is the women who are HIV infected, and it compares women at risk versus women who become infected, is their inability to negotiate being able to use condoms or other methods of prevention, or negotiate when and if they actually can have sex. And then the third thing that people tend to look at and have paid attention to is the other imbalances, this issue of HIV risk behaviors, so that women who are HIV infected and women who've had sexual violence have a much greater rate of HIV risk-related behaviors. So, for example, you'll see that a woman who's had sexual violence works at this from a much lower self-esteem, but they also have a larger number of sexual partners. They'll engage in more risky sexual acts, anal sex, sex without protection, and there's a real lack of a balance in the power dynamic in the negotiation of sex. And they tend to be women who also end up at risk for repeated instances of sexual violence. So when we look at this, and we started to think about, so what's actually missing here? So one of the things, you can talk about this from the point of view of, oh, she had too many partners, oh, she couldn't negotiate a condom. But the other thing is, growing along with this in parallel has been a greater level of understanding of what's happening in the female genital tract and what the actual physiology is of the female genital tract. And we've been trying to benefit and sort of intersect this kind of information. So one of the things that is missing is, how does having had sexual violence affect your biological risk for HIV infection? And we've, over the past few years, been able to talk about biological risk for HIV from a much more knowledgeable point of view. So it's not just sex, HIV risk, but it's all the other things that are going on. There have been a number of projects that have come along. It's almost like a tipping point. So in our Office of AIDS Research, we sit in the Office of the Director, we have an advisory council, and we did a project, or did one of our advisory councils around women's biological risk, taking it from the very basic science point of view. And I'll talk a bit about some of that information in a second. Around the same time, the White House actually did their Women and Girls HIV/AIDS Awareness Day on sexual violence and HIV in women and girls, without there being a conversation between the different groups. We, OAR, with the Social Science Research Council and UNAIDS, and this was brought to us by the Social Science Research Council, started talking about, well, how do we learn more about what these possible biological risks are? And so we sponsored a meeting that brought in people from around the world to talk about the biology of women's risk. And it was a meeting that was held at Greentree, which is kind of the Camp David of the UN, to be able to sit and get people in a think tank for a couple of days to kind of hammer out. We had everybody from mathematical modelers to people who do genital tract immunology, general immunologists, people who actually see women in clinical care, and just sort of the wide range of folks who are very often not in the same room together, and the social scientists as well. And what they did was outline and modeled what you need to do about sexual violence and biomedical HIV risk, and then came up with defining a research agenda. And that was published in the American Journal of Reproductive Immunology in a special issue from November of 2012, rather. In 2014, we do the Trans-NIH Plan for HIV-related research, which lays out what the plan is for doing research and what the priorities are that will be taken up by both NIH, but also is used by external researchers to determine kind of what's available for funding and how funding will be matched. And without us mentioning it, it was listed as one of the priorities when we bring in internal and external advisors, starting in 2014. It was also brought up as a priority for 2015. And in 2016, it's actually been fleshed out to not just looking at sexual violence itself, but also looking at trauma-informed issues for trying to do HIV-related research in women. And then there's a White House task force on violence against women and HIV, which has been contributed to by all of the major HHS agencies, running the range from the research agencies to the care agencies like HRSA, et cetera, to justice, education. And within NIH, it's actually been a very multi-collaborative group with representation from the Office of Research on Women's Health, National Institute of Allergy and Infectious Diseases, Child Health and Human Development, people from National Institutes of Alcohol and Alcoholism, Institute of Drug Abuse, and I'm trying to think who else am I leaving out, mental health. And so all of us have come together to talk about the projects that we've been doing and the projects that are being put forth around these issues of research on violence against women and HIV for this White House task force. So I'm going to give you a quick anatomy lesson. If I cut you in half this way, if you're female, this is what female genital organs would look like. I guess that. Is it bottom? So vagina, you can see the opening of the cervix, which is the lower portion of the uterus, and it's all contiguous. I don't know if you can see how sort of the pink goes all the way up through the lining of the uterus, and then it goes out to the lining of the tubes which sit over the ovaries. That's one contiguous path. The beauty of that one contiguous path is all of these have their own immune function, and the design of that immune function is to keep, as Lauren talked about, sort of protection from external things. And one of those things that it protects you from is HIV. There have been folks who've really devoted their entire careers to this. Charles Weir from Dartmouth, and he's actually a physiologist, does human genital tract immunology. And what this shows is as you go up the genital tract, and this is looking at the difference in cells from up through the vagina, the cervix, inside the cervix, uterus, tubes, the cells may look somewhat different. And then also you have CD4 cells, macrophages, dendritic cells, a variety of different cells that actually have immune function and immune protection that exist along the genital tract. And these folks have been studying this and looking at how you can infect those cells with HIV. This is important because a number of other factors have come along, that it's not just the cells, but sex and semen also may play a role in whether the risk, what the genital tract immune function is like. So it can increase, the presence of semen can increase inflammation, which puts you at greater risk for HIV. It may disrupt the barrier, the epithelial barrier, the cellular barrier in the genital tract. You can transport viral particles to submucosal area as enhanced by both the presence of semen but also the presence of sperm. And it also can alter the microbiology of the female genital tract, which puts you at greater risk for which can put you at greater risk for HIV. So this normal female genital tract microbiota is actually protective, and when that's altered, sexually transmitted infections, the presence of semen, the activity of sex, it can also put you at greater risk. And the other things people have talked about are whether or not hormones may, with change over age, change with the menstrual cycle, change during pregnancy. Some of Weir's work has shown that during the menstrual cycle, around the time of ovulation, a period of time when you don't want someone to recognize sperm as foreign, there's actually a dampening of the genital tract immune function that allows sperm to get up through the cervix and fertilize an egg. And they can call this period of time the window of vulnerability. Pregnancy is thought to also have a similar window of vulnerability. Otherwise, you treat the fetus as though it's a foreign object. Of late, there's been a discussion about whether or not exogenous hormones, for example, Depo-Provera, depo-medroxyprogesterone acetate, injectable once every 3 months, really very commonly used method of contraception, particularly in young women, because it works for 3 months, whether or not that can increase the risk. And so these are some of the issues that are being discussed about what are the variety of things that can influence the female genital tract. So our effort is to really better understand female genital tract biology, what increases or protects it from HIV infection or increases the risk. If someone has sexual assault, is it that current event that puts you at greater risk, or is there a change from the tissue damage that may occur with sexual assault that alters the genital tract immune function? And how does that affect your future HIV risk, even if you're having sex with somebody where it's consensual, but that person may be infected? And then also, what we're also working on is how we analyze this integrated behavioral and biological risk for HIV in someone who's had experienced sexual violence. So there have been a number of things that have done. I'm almost done. One is the Centers for AIDS Research, where are these multidisciplinary centers that are funded through the National Institutes of Health that are external centers across the country, and they also do some of their work internationally. It's an opportunity to take advantage of NIH or HIV funding that occurs, and also the wide range of researchers from basic science to clinical to behavioral scientists. And so we funded 3 supplements. National Institute of Allergy and Infectious Disease funded another supplement to really start to give us some pilot data around this issue. And the 4 supplements are listed. The immune effects of sexual violence and associated HIV risk. This is important because this study takes women in a sexual violence clinic, looks at what their immune factors are, at the time of presentation and then follows them over a number of months to see how these immune factors may in fact change. It also collects samples of tissue and cells so that you can actually look at working at infecting those cells with HIV and see what that difference is over time. And then you can see the others that are listed there as well. One of these studies is being funded in Africa. There's also some studies looking at just the general mucosal immune environment and seeing how that's altered and what that can mean at the cellular level for the ability to infect with HIV. And then there are a number of a number of meetings that are being conferred. One is that will be done by NIH is to look specifically about the ethics and doing research in people who are at risk, because it really tells us we have to looking at women under the age of 18 to really understand these risks well. And there are tremendous ethics with being able to do research in this younger than age 18 population. And then most of the research studies that are being conducted around HIV and women's risks are now including questions that will ask about sexual violence. And so if you want additional information about this, there are a number of places to go. On the NIH website, you can get the Trans NIH Plan, which will flesh out HIV and sexual violence related research and what the issues are. You can look for the Centers for AIDS Research supplements, and then there are a number of RFAs that will come up over the next couple of years to talk about some of these things. And then the Centers for Disease Control has a tremendous amount of demographic information about sexual violence and then the intersection of sexual violence and intimate partner violence and HIV risk. Thank you.
Good afternoon. My name is Cerise Elliott, and I'm a member of the Women of Color Committee. And I'm here to introduce Dr. Tamara Harris. She's the chief of the Interdisciplinary Studies of Aging section in the Laboratory of Epidemiology and Population Science at the National Institute on Aging. And she's going to talk about disability outcomes, data from health and aging and body composition study.
Thank you very much to the organizers for inviting me to speak and for that nice introduction. So I'm going to spend a little bit of time today, see if I can get this so that it actually picks up my voice. Okay, I'm going to spend a little bit of time talking about disability, and then I'm going to show some data from a study that I've designed, but that our group has carried out for the past 15 years, and that is available for other people to collaborate with us and also to analyze the data. So please get in touch with me if you have any interest at all in analyzing data from the study. So let's see if I can figure out how to do this. The top button?
No, left, right.
Left, right? Okay. Okay, there we go. Now, people tend to think of older people as one large group of individuals, but in fact, from the point of view of the National Institute on Aging, we see the older population as very heterogeneous and at least dividing into 3 different groups depending on health trajectories over the lifetime. So that is that in terms of things that happen, the genes, health behaviors, education, and life events tend to separate the cohorts, and this is the period of time that was discussed earlier from the ARIC study and the Cardias study, so that by the time that people get into old age, they are either frail, their usual aging, or they might be considered healthy agers. And the thing that's interesting about this is that people contribute from these groups differentially in terms of health outcomes. The study that I'm going to discuss in terms of this paradigm is the Health, Aging, and Body Composition study. And this is a hypothetical trajectory that we think many people follow in relationship to weight, illness, and risk of disability. That is that people are going along in their usual state, and then they'll have some sort of catastrophic incident, health incident, like a hip fracture, pneumonia, congestive heart failure. And basically, most people experience an incomplete recovery from that episode that leads them then to have a lower level of energy, a lower level of function, and eventually they pass through the threshold for what we call functional limitation, and I'll define that in just a minute, until they come to the threshold for disability. This diagram was originally created for people who had AIDS in the period when we had no treatment for AIDS, and in fact has also been adapted for malnutrition as well. Now, the study itself was considered, we started this study because with the idea that change in body composition is a common pathway by which weight-related health conditions contribute to risk of disease and disability. And we started this study 15 years ago with a group of 3,075 men and women who were initially aged 70 to 79. And we had 4 race ethnicity groups. The study was 42% African American. And we did that because we wanted to get 4 separate estimates of what those changes look like in terms of the subpopulations. So we began the study in 1997 and 98 in Memphis, Tennessee, and Pittsburgh, Pennsylvania. And at baseline, everyone who came into the study had to tell us at least twice that they were able to walk a quarter of a mile without difficulty and up 10 steps without difficulty. And that was the primary outcome of the study, functional limitation, which was incident difficulty walking a quarter of a mile or up steps, persisting for 6 months. This is the schematic that we used, and we felt that we wanted to include a lot of information about past history. Most of that information we got through health history, looking at sociodemographic status, psychological factors, and weight history. And then we had a core examination where we brought people to a clinic, and that core examination consisted of body composition studies, walking endurance studies, tests of strength, physical performance, where people would do things like have timed walks and drawing of blood. But the most important thing for the study was really to have information about weight-related health conditions. And we tried to get information about not only about clinical conditions, but about subclinical conditions as well. And then we had the outcomes of the study. These are some of the characteristics of the study, and you can see that among the body mass index, the men, black men and white men had about the same range of BMI, whereas the African American women were much heavier, a BMI of about 30 as the mean. When we looked at percent fat, though, you could see that the percent fat was about equal because of the different distribution in terms of subcutaneous versus visceral fat in the subpopulations. Lean mass was slightly higher among African Americans. Days of hospitalization were higher among African Americans, even though everyone told us that they were at the same functional level. We could see signs that the African Americans were at increased risk. PACC years were lower in the men and about equal in the women, and the proportion that were hypertensive was much higher in the Black population. I'm going to skip this in the interest of time, and I'll be happy to come back to it. So over the 13 years of the study, if we look at the percent who had incident functional limitation, these figures were really astounding when I ran them last night. The white men, 67% of the white men had persistent disability, problem walking up walking a quarter of a mile or up 10 steps. Black men, 73%. White women, 72%, and the black women, 80%. And I think that this really is very consistent with all the data that's been shown at this meeting for the differences by race and gender. And so what about risk factors for functional limitation? These are just the risk factors for the Black women. And what I thought was important to point out here, I'm going to go through this and sort of read through this. It's using the same paradigm that we used for the study. So first in the area of past history, measures from the core examination, from the mediators of disease, and then from the outcome. So the first thing is that for past history, history is very important. So education or family income, all of these risk factors were significant at the point less than 0.0001 level when looked at in a univariate sense, and all of them maintained significance when put in a multivariate model. So number of hospitalizations prior to coming into this study was a risk factor for disability over the next 13 years, PACC years of smoking, and self-rated health. In the area of core examination, body mass index was a risk factor for mobility disability. the penetration of fat into the muscle of the leg, which I'm not going to have time to talk about, but is really a new risk factor that's emerged from this study, was a risk factor for mobility disability, as was lower grip strength. But if we look at the diseases that were present at baseline that predicted the future onset of disability, depression, scoring high on a screening test for symptoms of depression, both osteoarthritis of the knees, having been told by a doctor or other health provider of having osteoarthritis, and then actually saying that in addition that people had pain due to osteoarthritis of the knees, both were predictive of future mobility disability. Lower extremity arterial disease measured by blood pressure in the arm and the feet, coronary artery disease history, and then three other factors which we had thought were mediators that fed back to body composition, which were exercise, cystatin, which is a marker of renal disease, and fasting glucose, a marker of diabetes. But the fasting glucose actually extends beyond diabetes because diabetes itself was not a risk factor for disability, whereas fasting glucose was a risk factor for disability. Now, what happens if you include functional limitation? In aging, there's a lot of controversy about whether diseases are actually the thing that predicts what's going to happen to you in the future, or whether it's the presence of disability, and it doesn't really matter what diseases you have. So I went on to look at walking speed and reported ease of walking distance. And you can see that several risk factors dropped out, but the number of hospitalizations prior to coming into the study, pack years of smoking, lower extremity arterial disease, renal disease, and heavy body mass index, osteoarthritis of the knees, and symptoms of depression all continue to contribute to risk of mobility disability. And the thing that's really striking, and is striking in terms of the entire study, is the fact that past history contributes so strongly to what happens in old age. That is, that we're not really discovering, for the most part, new risk factors, but what we're discovering is that people have the product of what's happened accumulated over their lifetime. So if we could make interventions earlier in the lifetime on the diseases that are common in old age, but much earlier, we have a chance to actually reverse the mobility disability and to break the cycle of lack of independence in old age. So I just wanted to close by thanking you very much for your attention and to welcome any questions you might have. My email is in the, I'm on the comment directory, and we have lots and lots of data, and if anybody's interested, I really would like you to get in touch with me.
Thank you. Does anyone have a question for Dr. Harris?
Just one quick question about the model. Did you include caregiving in social support? Caregiving?
It turns out the caregiving was a factor, but it wasn't, it was of moderate significance, but it wasn't of major significance. Actually, what was important was working. It turns out that people who are able to continue to work in old age, and we found that if you look at the proportion of African Americans who are working, it's substantially higher, which we think is really related to income. Yeah.
Thank you, Dr. Harris. Our next presenter is Dr. Tiffany Powell-Wiley. She is Assistant Clinical Investigator for the Social Determinants of Obesity and Cardiovascular Risk at the National Heart, Lung, and Blood Institute, and she will be discussing neighborhood environment as a social determinant of obesity and cardiovascular risk.
So I'll be talking about obesity as a cardiovascular risk factor in particular, and highlight some data that suggests it's particularly pertinent for women of color, but also talk about neighborhood environment in particular as it relates to the development of obesity. So as most of us know, obesity has become an epidemic in this country, But what isn't as discussed as much are the disparities in obesity prevalence in the U.S. population in particular. Data from the National Health and Nutrition Examination Survey shows that women of color, particularly African American women and Mexican American women, have the highest rates of obesity as defined by a body mass index at or above 30. And the data shows that while the obesity prevalence is leveling off or appears to be leveling off in the U.S. population, most recent estimates show that almost 60% of African American women in particular have a BMI at or above 30. So there's definitely controversy as to what constitutes cardiovascular risk, particularly in relation to a BMI between 30 and 35. But what we do know is that grade 3 obesity, or the highest level of obesity as measured with a body mass index at or above 40, is most prevalent amongst women of color, particularly African American women. Data from NHANES shows us that 16% of African American women have a BMI over 40, as compared to 8% of all race and ethnic groups. And more studies are showing us that the highest rates of BMI in particular put individuals at risk for cardiovascular events, but even at risk for all-cause mortality. And so data from the Black Women's Health Study, which is a population-based cohort of women across the United States, shows that when we look at the relationship between body mass index and all-cause mortality, we see a gradient, particularly for those BMIs above 35 and well above 40, where those highest BMIs are associated with higher rates of mortality. And when we look, those individuals look specifically at cardiovascular death in relation to body mass index, when compared to normal weight individuals, women who had BMIs above 30 and as well as above 35 to 40 were at highest risk of cardiovascular death. Data from the National Cardiovascular Registry, or Action Get With the Guidelines Registry, also suggests a relationship between class 3 obesity or grade 3 obesity and mortality, particularly 30-day mortality after myocardial infarction. When we look specifically at those with class 3 obesity as compared to those with class 1 obesity, those with class 3 obesity had the highest risk of 30-day mortality, despite the fact that they presented at a younger age with acute myocardial infarction or heart attack, as well as the fact that they presented with a lower burden of cardiovascular disease. And so the question becomes, what really leads to this higher risk of death at 30 days, despite these discrepancies in disease burden? And so we understand that obesity is a cardiovascular risk factor and contributes not only to morbidity related to the weight itself, but also an increased lifetime risk of diabetes and subsequent cardiovascular morbidity and mortality. And it contributes to increasing costs related to cardiovascular disease and the disproportionate burden of cardiovascular disease, particularly among African American women. And this relationship between obesity and cardiovascular risk suggests the need to identify the potential causes that lead to higher rates of obesity amongst African American women, and in an effort that we can understand how these causes may help us develop effective interventions for specific populations. And so we've looked, in a review, we've looked at what we deem to be the potential reasons or causes behind the genesis of obesity in African American women, and we divided those up into three specific areas, the first being biology, the second being behavior, and the third being in particular what we term social determinants of health, either psychosocial or environmental factors that may play a role in the development of obesity, particularly for African American women. And what I'd like to focus on now is just really some of the data that we have developed or that we've analyzed in relation to neighborhood environment and how that relates to obesity. And while we haven't been able to look specifically at African American women in the cohorts that we have looked at thus far, we have been able to really tease out a relationship between neighborhood environment and weight change over time in a population-based cohort. And so one way of thinking about neighborhood environment as, or one way of measuring neighborhood environment as a social determinant of health is in measuring a neighborhood's environment as it relates to socioeconomic status on the neighborhood level. And this can be thought of as an objective measure of environment and really as a proxy of the types of resources that are available in that neighborhood, whether it be food sources, areas for physical activity, or potentially areas for safety within that neighborhood environment. One method that has been used and what we use in measuring neighborhood socioeconomic status is the development of what's called the Neighborhood Deprivation Index. And this is based on US Census level data, particularly at the block group level, which is the smallest neighborhood unit provided by the US Census. And these data allow us to aggregate specific measures from the US Census into a measure of deprivation or a measure of socioeconomic status at the neighborhood level. And what we have done is used statistical analyses to tease out a measure of deprivation based on 6 different areas, particularly education at the neighborhood level, the level of income and poverty, residential stability, or whether people, how long people have lived in that neighborhood, housing conditions of the neighborhood, the racial composition of the neighborhood, and employment and occupation status of those within the neighborhood environment. And while there have been several studies that suggest a cross-sectional relationship between neighborhood environment and obesity, or prevalent obesity, there has been really limited data on how neighborhood environment relates to weight change over time, with mixed results in prior studies looking at this issue. And so to utilize longitudinal data available on environment and cardiovascular risks, we've looked particularly at a cohort called the Dallas Heart Study, which is a cohort based in Dallas County, Texas. It was designed as a cohort to look at specific social and biologic factors that relate to the development of cardiovascular disease. This was a probability-based sample originally of the Dallas County population. And at baseline, individuals were adults aged 18 to 65. The cohort was designed to be ethnically diverse, where half were African American. And so it was designed to look at race-specific outcomes. However, race-sex specific outcomes were limited due to the power. And sample weights were calculated for this cohort so that inferences could be made to the population of Dallas County as a whole. And so one of our first projects looking at the relationship between neighborhood deprivation or neighborhood socioeconomic status and weight change was looking at individuals who had been living in the same environment, the same neighborhood, over the entire study portion, so over a 7-year period. And what we first determined was that there were actually differences based on how long individuals lived in their neighborhood, or there was an interaction between time in neighborhood and the neighborhood deprivation index. So there were differences depending on how long somebody lived in their neighborhood, there were differences in the relationship between deprivation and weight change. And so what we looked at were several different models, but as you can see, we have the different model types on the x-axis and the change in weight over the 7-year period for every 1 unit change in deprivation on the y-axis. And for those who had lived in their neighborhood the longest, meaning they had lived in their neighborhood over the median time of 11 years, they had significant weight change or a significant increase in weight relative to neighborhood deprivation. So the higher the neighborhood deprivation or the lower the socioeconomic status, the more weight they gained over time. And this was independent when we looked at adjusted models. First, we adjusted for confounders such as age, sex, race, socioeconomic status, and smoking. But we also looked at behaviors like physical activity as potential mediators, and still saw this relationship as evidenced by the model number 2. We then looked at the relationship when we adjusted for what we termed perceptions of one's neighborhood environment, meaning how they perceive the resources, what they perceive to be available resources in their neighborhood, such as resources for physical activity, resources for healthy foods. And again, we saw that there continued to be this relationship between higher deprivation or lower socioeconomic status and higher weight gain over the 7-year period for participants in this study. And so this led us to look more closely at this relationship to really tease out if, for instance, if we saw a change in the neighborhood environment over time, for instance, if somebody moved over time, would that change in neighborhood environment also affect weight change? And our hope was to look at both that change in neighborhood environment in relation to weight change and incident diabetes in a protocol here at NHLBI. And so just to give a sense of what we were looking at conceptually, we were trying to not only look at this relationship independent of confounders, but also to, again, tease out whether these potential psychosocial mediators played a role in this relationship, or could there be some explanatory, could some of the relationship between change in neighborhood environment due to moving and weight change, could that be explained by these psychosocial factors related to perceptions of one's neighborhood environment? And we also wanted to, again, see whether length of time in neighborhood moderated or modified the relationship between change in neighborhood socioeconomic environment and weight change, again, providing a little more evidence of a potential relationship between socioeconomic environment and weight. And so when we think of looking at the change in neighborhood socioeconomic environment related to moving, we understood that because we were looking at a natural experiment, what people do over a specific amount of time, over a 7-year period, we weren't necessarily randomizing people to moving versus not moving. And so we had to in some way control for the fact that moving in this case was not a random event, that there had to be some way to correct for the fact that moving had to do with other factors besides just the need to move for those individuals. And so we use what's called a Heckman's correction factor to account for this non-random chance of moving over time, and specifically the non-random chance of moving to an area of higher deprivation or lower socioeconomic status. And this correction factor took into account specific characteristics of the participants that may dictate why they would move. For instance, age, sex, race, their education level or income level, whether they owned a home or whether they rented a home, and also whether they were married or single. And these have been looked at particularly in econometrics literature, but had not been used as much in the health literature. But if one is familiar with a propensity score in the cardiovascular literature, for instance, or clinical trial literature, this Heckman's correction factor can be thought of in a similar manner. And so again, we wanted to see this relationship between change in neighborhood deprivation, this time related to moving to an area of higher deprivation and weight change over time. And again, the x-axis shows our the various models that we looked at, first adjusting for the confounders, and then adjusting for perceptions of neighborhood environment as potential mediators. And what we saw for the overall population is that for those who move to an area of higher deprivation or who move to an area of lower socioeconomic status, as shown under overall on the graph, those who moved to an area of greater deprivation had greater weight change over time. And again, wanting to tease out this relationship about a length of residence to see if that modified the relationship, we stratified by median time in neighborhood for those who had, again, moved to a new neighborhood at that time period. And for those who had lived in their neighborhood the longest period of time, we continued to see the relationship where moving to an area of greater deprivation was associated with greater weight gain over the 7-year time period. And so these data really pointed to neighborhood socioeconomic status as a specific risk factor or particularly related to weight change in this population. And so our hope is that we'll continue to tease out what may explain this relationship. We're looking at alternative measures of neighborhood socioeconomic status, particularly measures such as home value, which can be measured more easily than census level data. It's measured more frequently, and so you can look at more dynamic change over time. And we would like to look at that in relation to weight change in the population. But we also plan to look at built environment measures in this in the context of how they may explain some of this relationship, particularly things such as neighborhood walkability, and access to food stores in these neighborhoods. We're also looking at additional outcomes, particularly how neighborhood socioeconomic environment relates to the development of diabetes in this cohort, as well as the development of other cardiometabolic risk factors such as hypertension and hyperlipidemia. But more importantly, in relation to how we might be able to improve health in communities, we hope to incorporate this type of neighborhood environment data into the development of community-based interventions focused on improving physical activity and dietary intake and reducing obesity and cardiovascular risk. And so with our current studies, we at least have some evidence that cumulative exposure to neighborhoods may impact weight change. And right now, we have looked at psychosocial or behavioral factors as potential mediators, but we have not found one that really changes the relationship thus far. But these data suggest that these at-risk neighborhoods really may serve as targets for community-level interventions for reducing obesity and improving cardiovascular risk. So I'd like to acknowledge those who worked here and elsewhere on these projects, and I'd be happy to take questions.
study had immediate family members or close friends that lived within the same neighborhood and potentially account for that? Because there have been some other studies that clearly, if you hang out with your friends and your friends have certain types of eating patterns or caloric intakes, then you need to adapt to that. So one of the things I was kind of curious about is whether or not there was, or if it's even able to do, an analysis of are there other family members or friends that are living within the same neighborhood and see a difference maybe along that stratification factor as well as actually staying in the neighborhood for a long time.
No, that's a great point. I think you're alluding to some of the data regarding social networks in relation to the development of obesity. That data was not available at baseline on who was living in the household or data on spouses or that type of thing. We do have data on spouses at follow-up, so that may be something that we could look at. But in our multi-level modeling, we do attempt to control for clustering of individuals in neighborhoods. So we do try to take that into account.
I was thinking along the same lines as Lauren, time in neighborhood and increasing number of invitations to parties.
Exactly. Like that. Right. No. Exactly. Definitely.
So same comment. Opportunities for social mobility, information about employment. Ways to kind of get out if that's the intent. It's all tied to the networks. I really like a measure of a neighborhood environment, incorporating some part of the network. May explain some of the variants.
Right. And we do, in some ways, we try to get at that measure of social cohesion with our psychosocial measure because it asks about the cohesion of the environment, but we didn't see any variability when we adjusted for that. But that in some ways gets at how close-knit individuals feel within their environment.
Our final speaker is Salman Tajuddin. He's a visiting postdoc fellow in the Health Disparities Research section at the National Institute on Aging. And he'll be talking about genome-wide analysis of carotid intima media thickness among African Americans. Thank you very much.
Thank you so much. And I would like to thank first the organizers for giving me the opportunity to discuss what we're doing at the Health Disparities Research section up in the Baltimore in NI. My work focuses on genomics of the Handles study, and today I would like to talk about the carotid intima media thickness and its genomic determinants. Yeah, you've seen this slide before when Dr. Cook was presenting. I just would like to reiterate and emphasize that there is a disparity in terms of cardiovascular mortality, mainly heart disease, which contributes for more than half of cardiovascular disease mortality. And as you can see, both Black men and women experience high mortality. And if you see African American women, they have even a greater risk of mortality than Hispanic men. And although mortality from cardiovascular disease is improving over time, this disparity is still persistent. Sorry, this is the data from 2008, and in 1995, the mortality between African Americans, the ratio between African Americans to whites was 1.5 times higher, and this mortality was the same when you look back to data to the 1950s. So over more than a century, still there is a gap in mortality, and what we believe is genomics may have a contribution in addressing and reducing the gap in this one. Another data I would like to emphasize is although there is this gap, it increases while individuals are aging, and that's true for both Black men and women. As it has been discussed previously, cardiovascular disease it's multifactorial in origin. There are multiple factors. The main one is aging. It contributes for cumulative increased risk of cardiovascular disease. And there are socioeconomic status factors, cigarette smoking, high cholesterol, elevated blood pressure, obesity, as it has been discussed earlier, diet, physical inactivity, and diabetes and high glucose level. And the common denominator here is that these risk factors are common among African Americans. For example, in our study, more than half of the study participants are current smokers. Physical inactivity and obesity, as it has been said, is common among African Americans. And another common factor for this is all these factors contribute to cardiovascular disease through atherosclerosis build up via endothelial damage and increased inflammation. So looking at the pathophysiology of atherosclerosis is that inflammation it promotes and it participates in all stages of atherosclerosis buildup. Looking at acute phase reactants such as CRP and phospholipase A2, they are highly associated with atherosclerosis development and plaque buildup. Looking at data among women only, they experience higher level of CRP, and that data is it's more significant actually among African American women. And our previous data from our previous study, we have shown that CRP is highly associated with oxidative stress, both white and African American women. So what is the best indicator then for atherosclerosis development? So what we know that intima media thickness, which is an arterial wall thickness through lipid buildup in the arterial system, it results in wall thickening and blood flow obstruction. And this arterial wall thickening, it occurs in the whole vascular system. What we know about carotid intima media thickness is it is a measure of subclinical atherosclerosis. And there has been previous studies which show that IMT actually strongly predicts future cardiovascular event. And studies among African American population from family studies have shown that IMT is heritable in that there are genetic risk factors which contribute for IMT development. And in this particular study, which is from 2002, nearly 40% of variation in intima media thickness among African Americans could be explained by genetic factors. So our aim was that to identify genetic susceptibility factors that could be associated with carotid IMT among African Americans. And we hope that by identifying these genetic susceptibility factors, we would be able to fine-tune the risk prediction for cardiovascular disease by adding genetic markers so that we would improve early detection of coronary heart disease. So this is the data which comes from the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study. It is an interdisciplinary, community-based prospective epidemiologic study conducted in Baltimore, in the different neighborhoods of Baltimore. It examines the influence of race and socioeconomic status on age-related health disparities. Initially, it recruited 3,700 whites and African Americans in Baltimore area. What is unique about this study is that by going out to the neighborhood and sending out these mobile medical research vehicles, we would like to enable recruitment and retention of non-traditional research participants into age-related clinical research. My focus in the data that I'm going to show you is on the genetic component of the study, although the study has behavioral social domains. And we focused on only genotyping African Americans for the genetic component of the study. And genotyping was done using the Illumina 1 million SNP genotyping platform. And we increased the density of the SNPs by imputing using the 1000 Genomes Project, the multi-ethnic panel. And for this particular study, we had around 600 individuals with carotid IMT data. And carotid IMT was measured using ultrasound on the left carotid artery, the far wall, and we took 5 data points and averaged them. This is a summary of the association analysis and quality control we applied. So we would like to estimate the point effect for the SNP, and we'd like to adjust for potential confounders such as age and sex. And as you know, the African ancestry genome is diverse, so and there is known population substructure, and we'd like to adjust for population substructure by including the first and principal components. And we applied the standard quality control criteria and defined genome-wide associated significance level like that. And what you see here is a quantile plot where we would like to see whether the p-values from our result is whether it is inflated or not. And under normal circumstances and under normally distributed data, what you'd like to see is the expected p-value to the observed one should be on the red line. And what you see here is at the tail of this curve is that you see a departure from the normal distribution where there is a strong evidence of association with carotid intima media thickness in our study population. So this is the overall study. This is a Manhattan plot where the p-values are plotted for each chromosome colored differently on the x-axis and the log p-value on the y-axis. Each bar represents each autosomal chromosomes, and the solid line is the genome-wide significance p-value at 5 × 10⁻⁸, while the dashed line represents the suggestive or informative association. As you can see, there are some hits on this plot, one in chromosome 1, another one on chromosome 2, and a third one on chromosome 4. And I would like to zoom in and show you the local LD structure and the genes that are tagged by these SNPs. The first one is the locus on MMA, C for all 51 locus. Here, what you see on the x-axis is the genes that are located on that particular region of chromosome X, and the y-axis is similar to the previous slide I showed you, where it shows you the p-values in log, and the most significant p-value is the one in purple, and the different colors shows you the local LD structure and the SNPs that are closely related to the lead SNP, which is shown on purple. The red one means that these 3 SNPs are closely related to the lead SNP. The yellow, the orange one between 0.6 and 0.8. The green ones, it goes on like that. So what we see here is that this SNP is tagging the MMA1 gene, which is a transporter gene, which is involved in the transportation of cobalamin from the cytosol to the mitochondria. And we know that cobalamin is important in various cellular metabolisms, including methionine and succinyl-CoA. And this is the gene that is we found a hit, and what it does, as I said, is it transports cobalamin into the mitochondrion. And so if this SNP results in a dysfunction on this gene, what it results is there will be lower production of methylcobalamin that results in increased buildup of homocysteine in the cell. And we know that increased homocysteine levels is related to endothelial damage and atherogenesis. So this is like a support from the literature. Another hit we found is in the COPS8 CXCR7 locus, where the SNP is located in the intergenic region, and it is strongly associated with IMT. The third region, what we have found is this SNP. It's also intronic, and it's located in the CAMTA1 gene, which is a transcription factor. And previous studies in a European ancestry population have shown that SNPs in this gene are associated with plasma fatty acid levels, and we're hypothesizing that it may be related to atherogenesis and atheroma development by altering plasma fatty acid levels, but that needs functional validation. And I'd like to show you a stratified analysis by sex, and the top panel is the results for women and the lower one for men. And as you can see here, there are some SNPs in chromosome 4 and chromosome 9 which are strongly, significantly associated with carotid IMT among women. And these SNPs are quite different from the one that you see in chromosome for men, which are located in chromosome 5 and 4. So this suggests that maybe men and women have a different risk factor for carotid intima media thickness and maybe subsequent cardiovascular disease development. So in conclusion, so this is a preliminary study. It's just one study. We need to replicate it and validate it. And as you know, JUAS doesn't in one study. But the preliminary conclusion for this study is that MMA1 and MMA and CAMTA1 SNPs could be a potential susceptibility marker for atherosclerosis development among African Americans and may provide new mechanistic insight to subclinical atherosclerosis. There are ongoing works for this project. We approached other African American cohorts from the Cogent and Charge consortia. So we're now pulling data from these cohorts and do a genome-wide meta-analysis. And also we have genotyped our cohort SNPs that are located only on the exomes of from the genome, and we'd like to identify association with these putative functional variants and validate their functional effect on IMT. We also would like to explore gene-environment interaction, particularly age, smoking, and socioeconomic status. And we have also another ongoing project where we'd like to see microRNA binding variants and hypertension among women. I would like to thank my boss, Dr. Evans, for giving me this opportunity, and also my lab mates and collaborators here in the intramural research program. And my work has benefited discussion with them. Thank you so much. And if you have any question, I'm happy to answer.
So how far along are you with the gene environment analysis?
Yeah.
Consider SES and some of the other environmental.
Yeah, that's really interesting, and actually we'd like to really tease out that association, but we'd like to first identify validated and replicated SNPs before proceeding to the gene environment analysis. So once we have the meta-analysis from the genome-wide association studies, the next thing we'd like to do is the gene environment interaction.
So, consider you were looking at large group and how about health ABC for validation?
Yeah, that's a good thing. Yeah, we contacted the Health ABC is part of the Cogent consortia. So I contacted actually Dr. Harris, and they don't have IMT data, unfortunately. Yeah, there aren't really a lot of studies actually. I would like to say that among African Americans, and so far we have contacted, I think, more than 10, 12, but like 5 of them had only IMT data and on limited number. So that really affects also the power of the study, I should say that.
Did you see any difference in the association with the SNPs if you differentiated by age, specifically targeting the lower end of individuals who, if you postulate that this is potentially a genetic risk factor, to see whether or not there was differential expression in certain genes in younger age group, because then those are individuals where if you somehow target some kind of therapeutic or monitoring intervention, you get a tremendous bang for your buck in terms of delaying that comorbidity in the very, people who are still at the prime of their life, in terms of working years and stuff like that. So did you see any cutoff between, if you had intimal media thickness at a certain age and then differentiated that out, maybe at the far ends of the spectrum? Yeah, looking at the extreme phenotypes. That is an interesting point. We haven't yet, mainly because, it's true that atherosclerosis development, it's a lifetime process. So looking at the different extremes of age may give you a good picture of the gene age association, actually, and you may get some interesting hits. But our sample size is smaller, so stratifying it may not give you a good power. So I think, and that goes with the gene environment interaction analysis. So what we'd like to do is get a bigger sample size and have a good power, and then do a stratified analysis with age, sex, and socioeconomic status, actually. Thank you.